Alrighty. So, based on your guys' requests today we're going to be talking about vaccines, cytokines, and the complement pathways. So first off with vaccines, we have a few different types that we'll discuss. First off, we have the live attenuated vaccine. And the way that these guys work is that they are alive, but they essentially keep on creating more and more generations of whatever the particular virus or bacteria is until it loses its pathogenicity, but can still create humoral or memory immunity. So the pros of this is that it's strong and it can create lifelong immunity. And the con is that it can actually cause disease because it is a weakened form of the antigen, so it can revert to an actually shit form and make you sick. So examples we've got adenovirus, polio, varicella, smallpox, BCG, yellow fever, influenza, MMR, and the rotavirus. And I just have to say, hilarious thing today. We had a patient, and the doctor was asking, he was like 64 or something. He's like, have you gotten the varicella vaccine yet? And the patient's like, no, man, I never got the chicken pops. And I had to bite my cheeks from laughing because I just, man, it's kind of nasty, like fried chicken cereal. Okay. Anyways, chicken pops. So next we have the killed or inactivated. And this is when they take the offending pathogen and then they inactivate it by either heating it up till it's dead or chemically make it inactive. So again, it causes a humoral or memory response, and the surface antigen is the epitope. The epitope, as we know, is the area or the spot where or a piece of what attaches to the antigen or antibody binding site. So the pros is it's safer than a live vaccine because you don't have something that can revert to a pathogenic form. And the bad part about it is that it's weak and you'll need some boosters for it. And so the mnemonic that we use for the killed vaccines is RIP because they're killed, always. That's for rabies, influenza, the polio Salk vaccine, and Hep A. So this is where I like to bring up that we have two different types of polio vaccines. So how do we keep this straight? Anybody got the mnemonic for how we can keep Sabin versus Salk vaccine straight in our heads? Well, I always use Sabin alive, Well, anyways. Any questions so far?
Nope.
Okay. So now we have subunit vaccines. And this is where you're only going to use a part of an antigen that will spark the greatest immunity. So the best part about this is you have low chance of adverse reaction because you might not necessarily be using the entire viral particle or bacterial particle for this type of vaccine. And the cons is that you'll get a weaker response and it is more expensive because you have to modify, either molecularly or genetically, you're going to have to modify whatever subunit you're using to create this vaccine. And the most famous examples are the Hep B and Haemophilus type B. And so Hep B, what is the marker that you have been vaccinated by Hep B vaccine? If you get a bunch of lab values of a patient's different antibodies or antigens, what is the marker that they've been only vaccinated by Hep B and not actually exposed to the live virus.
Surface anti-surface antigens?
Anti-surface antigen positive, and that's it. Everything else, E antigen, core antigen, all of those are negative. And that's because you're only using a surface protein. And so the beauty of it is that our cells will recognize the outer capsule of something like this, or Haemophilus, or Neisseria, pertussis, strep. They'll recognize something on the outside capsule. They'll create an antibody against that. So if we ever do come into contact with a lot of these, we already have this defense against their outer shell. So we're never actually exposed to what's inside, but we have a defense against the outside. That's what's cool about these guys. And then we have the toxoid vaccines. And this is just a toxin. Again, it's been denatured. So it's been rendered inactive to stimulate the response. So it can protect against bacterial toxins, like we've got tetanus and diphtheria. But again, it's not as strong because it is, again, kind of like an inactivated toxin. So you might need a booster, like we need a tetanus booster or TD, tetanus diphtheria booster, every 10 years after we've had the Tdap. Okay, any questions on vaccines? All right. So, what are examples of the killed vaccines?
Rabies.
Killed or inactivated?
Rabies, influenza, polio. And Hep A.
Which polio?
Salk.
R.I.P. always. Good job. Okay, so now we're moving on to cytokines. Cytokines, literally, if you break down the word, it's cell movement. Cell movement. So these guys essentially get cells' butts up and running. So they're broken down into different phases. We're going to talk about first just the cytokines that are secreted by the macrophages. So I group interleukins 1 through 6 because we've got this handy mnemonic here, but also it's because they essentially are the inflammatory response interleukins. So they create fever, inflammation, they bring about the white blood cells to the area of, whatever is foreign, and then they create antibody production. So the mnemonic is one hot T-bone steak. The hot, it refers to IL-1, which causes fever. The T in T-bone is for 2, IL-2, because IL-2 is responsible for T-cell activation. 3 is the bone, because it stimulates bone marrow production. And then the E, the E and the A are for 4 and 5 respectively, and that's because they stimulate B cells to create class switching of antibodies to IgE for IL-4 and IgA for IL-5. And then the K is for acute phase reactants, sort of. And so those, and IL-6 is also a big player in fever. So that is one hot T-bone steak. So interleukin 8 is necessary for chemotaxis for neutrophils. And neutrophils help to clean up infections in our body, so you can remember clean up on IL-8 as a mnemonic. Does anyone remember what the other neutrophil chemotactic agent is, or molecule is?
C3. No.
It's a C. It's the other
C5A? Oh.
C5, is it? Yeah, C5A. Right. We're going to go over it a little later too. But yes, C5A is also a neutrophil chemotactic factor. So now we got IL-12, and this interleukin helps to differentiate T cells into T helper 1 cells. So this is what happens in the thymic medulla. Once it's from the medulla into the medulla and then to the peripheral tissues, it gets exposed to IL-12, and it'll differentiate from just a general T cell into T helper 1 cells. But it also is important in activating natural killer cells. And then we have TNF alpha, tumor necrosis factor alpha. So this guy activates endothelium, recruits white blood cells, and causes vascular leakage. So one important thing to remember about is that it can cause cachexia. What's cachexia? Somebody tell me.
It's kind of like failure to thrive, but for adults.
Okay, well, it's wasting syndrome. A patient is losing body mass, muscle mass, body fat. They're essentially being eaten away. And TNF alpha is responsible for cachexia. And TNF alpha's original name was cachexin. Cachexin. So, if you remember that, you might remember TNF alpha can cause it. The reason that's important, because I think UWorld or First Aid or something, it does have the question where they'll have like an HIV patient will say, oh, this guy's lost 40 pounds in 6 months, and they'll say, you know, which of these cytokines is responsible for this patient's wasting syndrome? Boom. So TNF alpha is also important in maintaining the granulomas in tuberculosis. So that's why when you put someone on a TNF inhibitor, you have to check their PPD and see if they have any latent tuberculosis because of this. This is important in this maintaining the latency of TB granulomas. And TNF alpha, along with IL-6 and IL-1, are all mediators of fever and sepsis. So that makes sense with TNF alpha, because with sepsis, we're going to have vascular leak from TNF alpha and white blood cell recruitment. So these are the main players in sepsis. Any questions on the things secreted by macrophages? Oh, and again, going back to this thing about maintaining TB granulomas. So, if you see a question, it could either be, oh, is it TNF alpha that is the one that maintains the TB granuloma, or is it the macrophages? Ooh, stupid thing. Because they might tell you, oh, you just gave a TNF alpha inhibitor. What is the mechanism by which this patient just received TB? Well, they're not going to give you TNF alpha because that's, it's a TNF alpha inhibitor. So you might have to remember that it's the macrophages that are housing TNF alpha. Okay, so now we're looking at cytokines that are secreted by all T cells. So we got interleukin 2, interleukin 3. So we talk about them with the macros, but it's important to know that T cells also secrete these guys. So IL-2, like we said, in hot T-bone state, this is the T. That's because it helps stimulate cytotoxic and regulatory T cells, and also stimulates natural killer cells. So again, we're talking about acute phase, acute phase reactions. We're talking about cytokinesis. We're moving NK cells to the area of inflammation. Then IL-3, this was the hot T bone. This is the bone part of it because we're supporting growth bone marrow cells. So secreted by T helper 1 cells specifically, we've got interferon gamma. Interferon gamma Can be secreted by T helper 1 and natural killer cells. And this stimulates macrophages to kill pathogens. If you guys remember Dr. Why do I always forget her name? The micro lady from Kaplan. She had the Hulk hands. She was a Hulk smash. Moscatello, thank you. She had the Hulk hands. She was always saying, Hulk smash, when you turn the macrophages into the Hulk. That's interferon gamma. I like to think of it like you're giving them some kind of crazy energy drink, or maybe like a Four Loko, where they just go absolutely nuts, and they just start, they're really motivated to kill foreign objects. The other thing that's important is that it suppresses T helper 2 cells. So what stimulates T helper 1 suppresses T helper 2 and vice versa. T helper 2 cells release IL-4 and they suppress, and IL-4 will suppress T helper 1. But I'll let that go so we don't confuse ourselves. And then it also activates NK cells and increases MHC expression on the external surface, or on the cell surface of T helper 1 cells. Okay, so then we have the ones secreted by T helper 2 cells. So, interleukin 4. Again, we're talking about hot T-bone steak. This is the E in steak. And it's going to increase IgE production and as well as IgG. This guy promotes B cell maturation, promotes B cells to make the IgGs, and then it stimulates T cells into T helper 2 cells. I also didn't put here, but I mentioned it earlier. This is going to suppress T helper 1s. These two guys battle it out all the time for like harmony. So you can use them like beg for help. I've never used it though, so I just put that in because it's in first aid. So interleukin 5 in the hot T-bone steak. This is the A in steak because it promotes IgA production, or pretty much just class switching to IgA. And then interleukin 10 is important in decreasing the inflammatory response. So when we've got 2, 3, 4, 5, 6 TNF alpha all going nuts with creating an inflammatory response, once it starts getting out of hand, or maybe the pathogen is actually already getting killed, or maybe interferon gamma is just going nuts and the macrophages are just going crazy, that's when interleukin 10 is kind of like the chaperone. It comes like, all right, dudes, you've done enough. Chill the fuck out. Go home. So interleukin 10 is a depressor of the inflammatory response. Does anybody remember what's the other depressor of the inflammatory response? TGF-beta. TGF-beta and interleukin 10 are the ones that mediate the depression of the inflammatory response. And having a lack of interleukin 10 or a lack of TNF-beta is associated with autoimmune diseases because you don't have a way to stop this inflammatory reaction, so you're constantly going to have inflammation. Any questions on this page? All right. Okay, so complement. So complement system is a system of proteins that complement the innate and the adaptive immune system. And we have 3 different pathways: the classical, the alternative, and the lectin pathway. We're really only going to look at these 2 because this one, well, isn't very high yield and is pretty much the same as classical. So this is the complement system in general. So first, we're going to look at classical pathway. But what is important to realize from this diagram is that even though they have 3 separate beginnings, they all have the same ending, which is the MAC complex, the membrane attack complex. We'll get there. So what's important to remember about the classic pathway is that it is antigen-antibody complex mediated. So classical pathway. So we got a blood vessel, and we got an antigen. And yes, I'm using these from previous editor animations, so we're not monetizing this. So we have an antigen, and then we get an antibody that attaches to the antigen. So now we have an antigen-antibody complex. With antigen-antibody complex, that means we're talking classical. And the antibodies that are associated with the classical pathway are IgG and IgM, and that's where we get the mnemonic GM makes classic cars. And you can't see that too well, my bad. So IgG and IgMs are these antibodies that will attach to a foreign antigen in order to start this complement cascade. So you don't need to memorize this, but it's going to be a nice little thing to show you. So we got all these different C's that join together to make a complex. And then we got C3 that comes and joins a complex, splits into C3A and C3B. And C3A is responsible for vasodilation. Then we've got C5 that comes around, splits off, and C5A is also an important vasodilator in the complement pathway. And like we mentioned earlier, C5A is important for what?
Neutrophil chemotaxis.
Boom, neutrophil chemotaxis. All those little guys coming in. So then we have all these terminal complement proteins that come in C5 through C9. This right here is the MAC, membrane attack complex. It punches holes inside of an antigen, and then it causes apoptosis. And the foreign body is dead. Yay, classical complement pathway just survived. So now we're going to talk about the alternative pathway. And what's important to know about this one is that, again, we're going to have the common ending, which is MAC and cell lysis and apoptosis. But it is spontaneous, but that's not going to get tested on. Microbial surfaces is important. And it starts with C3. So what does that mean? It means that we have this foreign particle, a bacteria, and on a gram-negative, mostly bacteria, it's the lipid A endotoxin, which is the epitome, use that word since we saw it earlier, the epitome that is going to trigger the alternative pathway and essentially get C3 to show up. So if this is, the cell surface here, we have this lipid A endotoxin that's going to be right on the cell surface. So this guy has the endotoxin on it, which attracts C3, and then pretty much we're going to have a very similar pathway once we get to this complex. Okay, so this has a lot of B's, and you just remember that bacteria causes the BB complex pathway. Although I highly doubt that's something that specifically gets tested. And then this is when we get C3 again, splits off, we're going to have vasodilation, then C5 is going to come in and split, and it's going to cause its vasodilation, and then we're going to have neutrophil chemotaxis, and then the membrane attack complex will be formed once again. Boom, we get apoptosis. So that's the alternative pathway. I'm not going to go over the lectin pathway, because it's not very important, and it has essentially the exact same pathway as the classic. The only thing that you should know about this one is that it can be triggered by mannose. Other than that, nobody cares. I've actually never seen a question on the lectin pathway. So, We have a question. A 2-year-old girl presents the emergency room with irritability and vomiting. On physical exam, she refuses to walk and becomes very irritable with any movement. A non-blanching petechial rash is scattered diffusely over her legs. Her heart rate is 151, BP is 75/49, temp is 104, respiratory rate is 26, lab studies reveal sodium 131, potassium 3.6, chloride 93, bicarb 26, BUN 29, creatinine 0.8, glucose 59, white blood cells 21,700, 81% neutrophils. Blood cultures are drawn. A lumbar puncture is performed. An empiric antibody treatment is initiated with vancomycin and piperacillin tazobactam. Cerebral spinal fluid analysis shows an opening pressure of 217 centimeters of water and white blood cell count of 5,000 cells per millimeter cube, or 85% neutrophils. Glucose level is 15 milligrams per deciliter, and a protein count of 229 mg per deciliter. This child's infection is associated with a deficiency of which of the following complement molecules?
D.
So, we've got vomiting, we've got a non-blanching petechial rash, we got a patient with increased respirations, hypotension, tachycardia, fever. So what is this kid in? Fever, hypertension, hypotension, tachycardia, tachypnea. Well, we don't know that because we don't know the platelets. But, oh no, DIC would have decreased white blood cells. We've got elevated white blood cells. Fever, hypotension, tachycardia, tachypnea. This is sepsis. This kid's in septic shock. We got fever, hypotension, tachycardia, tachypnea, sepsis, and it's a bacterial sepsis because we've got an increase in neutrophils. So what kind of septic shock would cause a non-blanching petechial rash? What kind of bacteria would cause a petechial rash? All right, well, if we can't deduce it from there, let's go to the answer choices. Again, it wasn't discussed in the lecture I just gave today, but let's go through. What if we had a C1 esterase deficiency? Because we're talking about what deficiency would cause this picture.
That'll be angioedema, right?
Right, angioedema, so it's not this one. C2. Oops. Okay. Wow, I guess the answer is D. Okay, C2, anyway, I'll just go to C2 and C4 don't have any particular pathology associated with their deficiency, and a deficiency in decay accelerating factor would cause paroxysmal nocturnal hemoglobinuria. So the answer is D, because this kid has a Neisseria sepsis. Sepsis mediated by Neisseria infection. And we know that C5 through C9 is associated with the MAC complex. And if you don't have any of these and you lack the MAC, you're susceptible to Neisseria. I think there's an E in there. Does anyone understand that? I know it's kind of a tough question, but any question? And then as far as the cerebral spinal fluid, the only thing that you really need to know from there was that the glucose level was low, so you knew it was a bacterial infection. And the white blood cells in the blood is neutrophils, so you knew it was bacterial and not viral.
I had the drugs threw me off for this one, that's why.
Oh, the drugs. Well, and these wouldn't have worked because...
Right, yeah, and that's why I was kind of like, what?
Well, Vanco could have worked because it targets. But we know that normally we would either do third gen and Azithro or Doxy. And for something like this, probably IV. And that's all, folks. So again, any questions on this presentation before?
The decay accelerating factor is a CD55 deficiency.
CD55 and 59, correct.
Yeah.